Our next topic is about PCORI funding. I'd like to welcome Suzanne Schrant. She's the Deputy Director of Patient Engagement with the Patient-Powered Research Networks, which is a PCORI program. As many of you know, PCORI was funded through the Affordable Care Act back in 2010 and has a great deal of money available for research. So please help me welcome Suzanne Schrant.
Hi, good afternoon. Let's see, let me make sure I can handle the technology. All right. So I'm the Deputy Director of Patient Engagement for PCORI, and I'm going to talk to you a little bit about PCORI and our funding mission. I'll spend a little time talking about the Patient-Powered Research Networks, and you actually already heard from one of our funded awardees earlier this morning. And PCORI is just sort of a really unique opportunity to really get patients and their families at the forefront of funding. This is a picture of our Board of Governors. This is always here to remind you that we are not a government entity. Even though we were created by Congress and legislatively born, we're actually an independent nonprofit. We're a 501c1, and we are governed by this group of people, which is actually a mixture of patients and other healthcare stakeholders who guide us in our work. We are committed to fund somewhere between $3.5 and $4.5 billion between the time we were created and 2019, at which time we have to be reauthorized by Congress in order to continue existing. To date, we've funded just a little over $1 billion. We gave out our first awards in 2012, so we've been pretty busy. We've funded over $1 billion between 2012 and now, and are starting just now to see some results from that research because it does take a little bit of time. So this slide, I always get nervous when I'm talking to the rare disease community because you all are so passionate. I always love to come to rare disease events, and I'm a patient advocate and a patient myself. I have a juvenile idiopathic rheumatologic disease. So this slide I'm always worried about because I don't want you to be disheartened that we do not fund development. We don't do drug and device development. So that means PCORI may not be your sort of penultimate primary funding source, but I think we could certainly be part of your plan because we would definitely fund anything comparative. It all has to be clinical comparative effectiveness research around treatment, prevention, and diagnosis. So maybe for your particular area of interest, it would be about symptom management or better diagnostic options or better prevention options. And so we're still available for that type of funding, even in the absence of being able to fund drug development. The other type of funding that we provide, and I'll get to this at the very end of my remarks, is what I would maybe refer to as getting your ducks in a row funding. So we do sort of preliminary engagement type funding to get your team together, start strategizing about how you want to perform your research, where you want to go after research dollars. So I think we can be a part of a strategy for rare disease funding. I'll walk you through our 5 national priorities to actually give you a little more sort of anchor in where you might fit depending on your disease of interest. So first is that upper far right hand, the assessment of prevention, diagnostic, and treatment options. We actually think of this as sort of our classic CER program in that it's just sort of your nuts and bolts, drug A to drug B, or diagnostic option A to B, or prevention option A to B. And even though everything we fund is comparative, this is what we call our classic CER portfolio, which makes it a little bit different from the other 4 that I'll talk about. So the next one, moving to the left, is improving healthcare systems. This is really looking at delivery methods. So maybe in the rare disease space, you're looking at rates of diagnosis. Maybe there's an issue with people in rural parts of the country not getting diagnosed with this rare disease as quickly as they should. So what could you do to look at and compare diagnostic options? Is it about getting diagnosed through telemedicine, or is it about traveling docs that could go around? Is it about something online, some sort of intermediary to improve rates of diagnosis? It's really looking at that care delivery aspect at a system level to improve health outcomes. The next one, continuing to move to the left, is communication and dissemination research. This is all about how people receive and use information. So how can you get the information that parents of children and children themselves and adults with rare disease need when you're first diagnosed or even well into your diagnosis and you're really trying to grapple with the information, figure out where to go, how to find a clinician, how to find other patients. So this has been a really interesting area of our portfolio so far. Then addressing disparities, which as the name implies is really looking at those populations for whom impacts are particularly adverse and really focusing efforts on treatment, prevention, or diagnosis within the ambit of a particular population. And then lastly, the methods portfolio. So this is accelerating PCOR and methodological research. I won't even try to get into the sheer methods part of the portfolio because it's very long names and I am not a scientist and I would not be able to speak to them very eloquently. But the part I really want to focus on here is PCORNet, which is our large data infrastructure project, and it's housed under this methods portfolio. PCORNet is just a giant data project right now. So right now we're only doing a little bit of research. It's been a lot of infrastructure building. We've committed over $200 million to it at this point. So you just want to think big data, but on steroids, and run by patients and other stakeholders that can really have a critical influence in this world. So right now we have 20 PPRNs, or patient-powered research networks. And that means that patients are either leading or very heavily involved in these research networks. We also have 13 clinical data research networks, or CDRNs, and those CDRNs are run by big health systems or insurance companies or other large players in the system. And thinking about rare disease, if you look at our 20 PPRNs, around half are focused on one or more rare diseases. You actually heard from Pat Furlong this morning, who does the Duchenne's PPRN. We have the Phelan-McDermid syndrome PPRN. We have a rare epilepsy PPRN. We have several other that are really focused on the rare disease space. And then of our CDRNs, those 13 clinical data research networks, each one was actually required to identify a rare disease that it will conduct research on when we get to that phase. So we're now at phase 2. We had a phase 1 and a phase 2. We're sort of slowly ramping up and getting ready to start conducting research within this huge data system. So right now we're running 2 different studies. One is an aspirin dosing trial and one is an obesity trial. But one of the opportunities that's open right now, and open just to those PPRNs who are already in the system, is a demonstration project. So they can apply for up to $2.5 million to start running studies that matter to them, to the people that are on the ground dealing with these diseases and trying to find solutions for these diseases to manage them. So we're in an interesting spot at PCORI because even though we don't fund drug development, we certainly are very committed to rare diseases, and this is actually in our legislative creation. We have a specific focus on rare diseases. So we have a rare disease advisory panel that helps sort of guide our work in the rare disease space, make sure we're very tuned in to the needs of the rare disease community. When that PCORNet, that large data infrastructure system that I was just describing, when it starts to get very deep into rare disease research, they'll work closely with this rare disease advisory panel. There will also be a rare disease task force affiliated with PCORNet to make sure those studies are being executed and done in ways that really matter and make sense. And then we've already conducted a fair amount, or not conducted, but funded a fair amount of work in the rare disease space. And I can walk through these quickly and kind of tell you where they fit in our portfolio. This first one is about surgical options. So it's a comparison of 3 different surgical options for idiopathic subglottic stenosis. This is in our CER, that sort of classic CER portion of the portfolio. And it's about a $2.7 million project and has been up and running for a while now. Moving down to this, the galactosemia project, this is looking at, it's an observational study looking at exposure to milk product and if there's a way to sort of prevent harmful effects, harmful cognitive effects or developmental effects from milk exposure in galactosemia. And that one is also in our CER, our classic CER portfolio, also around 2.5. That one's actually at $2.7 million. The next one is looking at different entry sites for a shunt in types of hydrocephalus. This one was also in the CER portfolio. So we do have several of these in just our classic CER program. And that one is also about 2.5 million. And then this last one, or the next to the last, the Enhancing Genomic Laboratory Reports, I mentioned that CDR, the Communication and Dissemination Research Program, that's really looking at the impact of communicating information in the best ways. This is a project looking at how can patients or parents of newly diagnosed patients best sort of assemble information and figure out what their plan is. So they actually are pulling patients and parents in and saying, think back to when you got your diagnosis, you found out there was a genomic condition or genetic condition. What did you need and how did you need it? How did you need to hear it? Who needed to give it to you? What did you do with it? How did you put your plan of action in progress? And they're taking that information and giving it back to people who need it. So at the moment of diagnosis or at the moment you're receiving this information, this gives you a bit of a guidepost to figure out how to navigate this new world. And then lastly, I've already spoken about these PPRNs, but we're really excited about what this enormous network of patient-driven data can do and sort of what these research results will look like once we start queuing up this research. I just think it's a tremendously novel concept to really put patients at the helm. And if we think about data as our currency as patients, I think this is a really compelling case, and we're just very excited to see where it goes. So let me move into kind of the stuff that makes PCORI PCORI. It's in many ways, when I speak to the rare disease community, I feel like I'm preaching to the choir because you all already know this. It's such a committed group of people, whether it's patients and patient advocates and caregivers or the researchers or clinicians who are working on these issues. But what we do at PCORI is we really underscore these requirements because we tie our funding to it. And so in order to get PCORI funding, you have to have patients and stakeholder partners at the table along the entire continuum. So this slide, I always say it's not fancy. There's no bells and whistles, doesn't even have animation. It's very flat, but I think it's our most exciting slide because these are our 5 merit review criteria. If you're going to pass go and get PCORI funding, you have to hit all 5 of these. And if you'll notice, 2 out of 5 are about patients. So the first is patient-centeredness, and the second is patient and stakeholder engagement. Those 2 concepts, patient-centeredness and patient and stakeholder engagement, are kind of easy to confuse, so let me kind of separate them out for you. Patient-centeredness is really baked into the research question and the outcomes themselves. Is this something that actually matters to patients? Did the patient community elevate it and say, this is what we care about, this is the one thing I want answered? And the same is true of the outcomes. Are these the outcomes that matter to me? Is this what I am seeking? Is this the yield that I want to see in this research? Versus patient and other stakeholder engagement, which is really operationalizing that concept of patient-centeredness. Can I demonstrate that patients were at the table when we talked about this topic and that patients either brought it to me or strongly endorsed it and said, yep, this is what I care about, I want to see this move forward? Are you going to demonstrate in your proposal that patients are going to be there as partners all the way through the project, however that may look, whether they are designing parts of the protocol, conducting focus groups, doing interviews, recruiting, working on retention of participants? So it really can take a lot of shapes, but it's critical, and we want to see it in all our proposals and in our funded projects. So that third bullet is critical. We are not, when we're talking about patient engagement, we're actually talking about patient partners on the research team, not about study subjects. We definitely want to see the subjects and participants actively engaged and heavily involved and excited about being involved in research. But we think one of the means to accomplish that is by having real live people with these direct lived experiences at the table, conducting the research, shaping the research along the way. And then lastly, at PCORI, we also have a whole sort of department dedicated to stakeholder engagement. So the non-patient, non-caregiver stakeholders like industry, like training institutions, certainly clinicians and hospitals and health systems who also play a critical role in this process. So one of the things we created as a tool to help our applicants get a more concrete vision of what we meant by engagement in research was this engagement rubric. We actually extracted examples from our funded projects. At first, it was just our first 150 projects, and now as time has gone on, we keep revising the rubric and adding to it because we're learning so much about engaged research that we want to keep refining and adding to it. But what we did, we took all these examples and sort of packaged them into this tool, and it's organized chronologically by planning, conduct, dissemination, and then these 6 engagement principles. And I'll just walk you quickly through kind of what we mean and what we see in each of these categories. So for the planning phase, and you can see here, we've got sort of teased out what this can look like, identifying the question, identifying the outcomes, really being at the forefront during the sort of the preparation phase of the research. And I've got a few examples listed there that we've pulled from our portfolio. One that I think might resonate particularly for the rare epilepsy community is a disease study we did about 3 drugs used to combat childhood epilepsy. So there's, it's the 3-arm study, drug to drug to drug. And the original endpoint was which of these drugs will reduce seizure activity, period. That was the goal. And then when you got patients and parents in the room to really talk through the study design and think about the endpoint, everyone unanimously said, it's not just about reducing seizure activity. Our challenge with these drugs is the cognitive impact. And if I have no quality of life because it's just reducing me and I'm not able to participate in school or work or interact with my loved ones, then I want to figure out a balance. I want a reduction in seizure activity that still affords me a quality of life that I care about. So that's a minor adjustment from reducing seizure activity to reducing it within the context of also minimizing side effects. But it's so critical. And if you think about what might have happened had that study gone all the way to fruition with no involvement of patients and parents, it would have been a very different result. And so that's up and running now. We don't have results yet, but it's already promising to know that there's been a shift in the endpoint based on that involvement. Moving into conduct, and certainly this is the bulk of the study. Once you've got it up and planned, then you move into conduct, and this is where we're going to see so much rich involvement by the patient and parent community. There's a couple examples listed here. The first example is actually in a breast cancer study, and what was so compelling about this is it's such a great window into how we care so much about the real world. We want this research to matter and be reflective of what happens in the real world. And so originally, the inclusion criteria for this study, or exclusion criteria, however you want to frame it, this is about imaging. And so women who had bilateral mastectomies were excluded because according to clinical guidelines, they don't get imaging. They don't get studies because they don't have breasts and they don't, accordingly, they would not be candidates for typical imaging. And yet, when they talked to the patient partners who'd undergone bilateral mastectomies, many, many women said, I get imaging. I know it's not indicated, but I ask for it and I want it because I need to know that I don't have a recurrence. And so you would have left out this whole swath of people that in the real world on the ground are doing something, even though it's not clinically indicated, that's what they are doing. And so it was just a great kind of snapshot about being truly reflective of what happens. Another example from this sort of conduct and real world snapshot is a study looking at children with chronic lung issue. And the parents were filling out their PROs, or the patient-reported outcomes, and talking about quality of life. And the question was, how many days, complete days of work or complete days of school have we missed? And they, again, unanimously said, I don't experience my child's illness in 8-hour increments. I experience it because we were up all night last night, and now I'm exhausted today, and now I'm going to call in late to work. Or I experience it when we can't do what we need to do over the weekend because we're in the ER dealing with an emergency. So it was about how do we capture that piece? And often we don't have a validated tool yet. We don't have a validated outcome measure that will work, but we're learning as we go that we need to develop these and make them much more reflective of the impact. One piece that's sort of just inherent in this slide, and again, it's sort of like preaching to the choir. I know you would all understand this. As a patient advocate, I have to say it. I can't get through the slide without saying it. When we talk about recruitment and retention and the involvement of patient partners in a study, And what we already know from our funded portfolio, we already have metrics to sort of back up that when you have patient partners involved in a study, you often see better rates of recruitment of subjects and participants, because often these patient partners are conduits to their community. If I'm in a study, if I'm helping shape and guide the study, I'm going to be much more likely to go to my friends who have my disease and say, hey, you should really check this out. I think it's worth doing. What we want to be really cautious about, though, is framing it as though patient engagement involving these partners is for the sake of better recruitment and retention. That's just one great outcome. But the idea is not that you do it so that you have better recruitment and retention. That's just one part. You do it so that the study is more reflective, user-friendly, more feasible in my daily life, reflects what I care about, reflects what I want to see happen. So it's really just a slice that we're going to see better recruitment and retention. And so we're always careful about sort of highlighting that we've seen great recruitment and retention rates, because that's one small sliver of the positive outcome that can result from having patient partners. So I'll go to disseminating study results, and here certainly you all are so far ahead of the curve in the rare disease community because social media, you've already tapped into all these great channels and ways to share information and connect as communities. And I think what we're trying to really underscore is we understand that there's always going to be a place for the peer-reviewed journal, and that's great, it's important, but we really want information to get into the hands of people who need it. And so go to where patients already are. Go to their conferences. Go talk to them in language that makes sense. And if you've had patient partners involved in your work all along the way, they're going to be your biggest cheerleaders to go share study results, good, bad, or indifferent. They want the information out. It really is also about sharing. We can't have a lock and key on results and on data. We need this to all be shared and out in the community so that we can all benefit from it. And so those are the sort of the principles underscoring how we think about disseminating results. This is that catch-all part of the rubric. So we went through planning, conduct, dissemination. Now we're in the engagement principles. And these principles, the 6 of them sort of overlap: partnership, co-learning, transparency, honesty, trust, et cetera. Really, it boils down to respect each other. And if you're going to ask me to be on the study as a patient partner, really mean it, because I want this to be meaningful. I want to be a good partner. I want to contribute. And the same is true for patient partners serving on this study. If patient partners want to serve, then they should really commit to it and give it their time and energy. So we just want mutual respect and an understanding of everyone's roles. But a few of the things that have really jumped out, and sorry, the slide spacing is a little odd here, but a few of the things that really jumped out as soon as we started sorting through our portfolio and pulling these examples out that didn't fall into planning, conduct, or dissemination. They were much bigger than one chronological phase. The first was financial compensation, and this was really big. We heard from a lot of our patients, not even just in our funded portfolio, but outside of our funded portfolio, that said, you know, put your money where your mouth is, PCORI. If you're going to require that patients have to be on these studies, then be sure that they're written into the budget. Because what does that say? What's the value proposition if everyone around the table on the research team is getting compensated for their time, and yet the expertise that the patients are lending is not being compensated? And so we've now developed a couple tools. We've got a compensation framework on our website that you can use just as a guidepost. We don't have dollar rates. We're never going to put an hourly rate on a patient's expertise. It's just not, we just wouldn't do that. It's up to the study to figure out what makes sense and what will be accurate for that person's contributions. The next piece is training opportunities, and this really has to be bidirectional. It's not about turning patients into scientists or turning scientists into patients. It's about everyone meeting in the middle, understanding where we come from, how to talk to each other, and how to really benefit from our mutual expertise. And then lastly, and this is so logical that it's almost hard to say out loud, but of course, when you're scheduling meetings and scheduling time to be together, just be cognizant. So we've had studies where the patient partners didn't necessarily want to go to the big academic center. It was kind of foreboding. It wasn't familiar to them. They felt very intimidated. Certainly for the first meeting, they didn't want to go there. Maybe later, maybe after they were comfortable with everyone, they could trade off and spend some of their time meeting there. But early on, why not meet at the community site where your patients are, or figure out a virtual way to do that? There's just a lot of things to keep in mind to reduce those barriers to facilitation. So that was the rubric. Just to give you a flavor for sort of what this tool is and where it lives, it's embedded in our funding announcement. So if you apply for PCORI funding, you will fill out something that's basically a hollowed out rubric, and you will fill out how you plan to engage patients in the planning, in the conduct, in the dissemination. Same is true for stakeholders. If you've got clinician partners, hospital partners, industry partners, how are they going to be engaged and involved in all of this work? We then use it to evaluate in our merit review. So when we select these projects for funding, the rubric is a tool that the reviewers use. And I should say that we have patient and stakeholder reviewers. So it's not PCORI reviewing, it's external people, including patients and other stakeholders who use the rubric, who think through, does this look like a study I'd want to be involved in? Is it following all the rules that PCORI has laid out? This is just a real quick comment on sort of how we manage our studies once we fund them, because we really want every project to count. And so we produced this rubric. We started to see some benefit from the proposals that we saw. We could see people really working to really capture, this is how we plan to do our engagement. We want to make sure those patients are right there every step of the way. But what we realized was, after the application part, we had no mechanism for ensuring that this engagement would actually happen. So we'd have beautiful proposals, and then in our funded study, no mechanism for sort of overseeing that engagement piece. So we developed something called the engagement officer. And so if you're familiar with NIH funding or other funders, there's always a program officer who oversees your project. In PCORI's case, we offer contracts and not grants. So that means there's milestones and deliverables, and it's not sort of you get the funding and it's sort of done. This is an ongoing relationship. And so these engagement officers are actually involved on the kickoff call, articulating milestones, helping you meet your milestones and meet your deliverables, talking to your patient and stakeholder partners about, what has this been like? What could we do to be more helpful as funders? What information would be useful to you? So it's a very active, very proactive way to provide funding. And we're actually seeing this engagement officer concept take off with other funders. We've had a lot of interest in sort of replicating this notion. Okay, so now I'm going to close with what I referred to a little bit earlier about sort of the Get Your Ducks in a Row funding. So we've got a couple different programs that we fund under my team, under the engagement team, not under our science portion, that are really about kind of getting your community together, getting prepared for research, and thinking about what your endpoints, what your goals might be. And so I'm going to walk you through those programs. The first is the Engagement Awards program. This was launched not all that long ago, so even for PCORI, it's a relatively new program. And again, these are programmatic funding opportunities, so they are not research. And in fact, my biggest sort of caution to you is if you fill it out like you're filling out a normal research proposal, like you're submitting to the NIH, or even like you're submitting to PCORI science funding, your LOI will not be accepted, because the legal contract mechanism cannot support research. So it has to be programmatic and not research. So these provide support for projects that think about the integration of patients and other stakeholders into the research enterprise. And the way I really think about them is almost wraparound services for what PCORI funds. So how do we get, we being PCORI and our patient and stakeholder communities, the most bang for our buck in what we're funding? How do we make sure that what we're funding is going to get where it needs to go and be as meaningful as it can be? We do fund conference support awards, and I'll explain those in just a moment. So you can see the program budget there, which should be the same for fiscal year 2016. And each of these awards is up to $250,000. So they're smaller than our science awards. These aren't the $2.7, $2.8 million awards. But depending on what your purpose is, $250,000 can be quite a nice sum of money. So I think it can really be great for accomplishing the goals that we envision for this program. These have to go to organizations. They can't go to individuals. I will talk next about a program that actually can fund individuals, but this program, the Engagement Awards, is only for organizations. And again, it's just that note that we fund contracts, so just that you go in eyes wide open. This will potentially be a very different experience than having been funded under grants, because this is a multi-step process when you get funded through a contract. The engagement awards happen in 3 different buckets. We don't have a more scientific word. We always say things are in buckets. So these 3 buckets are knowledge, training and development, and dissemination. The knowledge awards are sort of bidirectional. It can be about increasing PCORI's knowledge of how people think about PCOR and CER, how they can use findings from PCOR and CER, and sort of how to think about that on the ground. Or it can be increasing your community's knowledge of PCOR and CER. So maybe just spreading the word about what this type of research is and how it works and how patients can actually be involved in the research enterprise. Versus training and development awards, which are really about capacity building. So this is upskilling your community, getting people lined up and ready to participate as research partners in research. And then dissemination, which is you can think of as laying the groundwork so that when results come out from either PCORI research or other funded research, there's people that are sort of ready and willing to receive those results and use them. So how do you build those conduits and pathways? The conference supports that I mentioned a moment ago, each individual conference award is up to $50,000, and they can fit into any of these 3 buckets, and they can even span all 3 buckets or 2 buckets. So it could be that you have one conference that sort of tackles all 3 of these concepts, and so those are pretty broad and can span more than just one of these ideas. So to give you a flavor for the types of things we've funded, this first award is a knowledge award, and the second 2 are training and development awards. It's thinking about getting the community together and prioritizing research questions. So how do you have a large conversation with all the members of your community about what do we actually care about funding? Where would we want to go to try to get our questions answered? How would this look if we were to do it? Versus this colorectal cancer screening initiative where it's upskilling. So this is one of those training awards where we're talking about building capacity to actually do this type of work. And then a similar award there at the third bullet, developing and implementing training to really think about what are the barriers. And so often you see in disadvantaged communities a big trust factor. Maybe you've historically been excluded or not felt very welcome in the research community. How do you overcome those barriers? So there's really multiple ways that these awards can look. We do have some engagement awards in the rare disease space, the PXE, and I always destroy this word, pseudoxanthoma elasticum. There's a sickle cell award. There's a few other rare disease awards in the engagement awards arena. And it's really just a great way to sort of get that community together and think about either building that knowledge base, upskilling, or thinking about disseminating study results once something becomes available. This is just an example of some of those conference awards that I already mentioned. The names are not very illustrative. It's really what I already described. It's about, are you building knowledge? Are you thinking about training and development? Or are you building pathways for dissemination? So I would really refer to sort of the concepts and the thoughts in the general engagement awards, all of which are available on our website, by the way. You can search for all of these awards and get an abstract. That'll really give you a flavor for the types of activities that would be fundable under these mechanisms. So a little bit on what we do not fund, and this will echo what I shared earlier. Anything that's really about development, whether that's development of a new technology, development of an intervention. So these awards can't be used for pilot studies, demonstration projects, validation of tools or instruments. A really tough one is they can't be about the provision of health care. So if you've got an idea, but part of it is going to be administering an intervention or actually actively providing health care, that's going to get it kicked out of the LOI phase. So you really want to think very critically about keeping your focus on PCOR, on patient-centered outcomes research. It can't be about the development of registries, but it could certainly be money that goes to a community that already has a registry or wants to think about outreach options or how to prioritize research questions, as you saw earlier. So I would think critically about kind of where you fit in that realm, and we're always available. Our entire engagement award team is available to answer questions. That makes us a little bit different from other funders in that we actually have a very open door policy. You can call anyone on our engagement awards team and actually, talk about your idea. Say, this is what I'm thinking. Do you think this would be a fit? Now, it's never a guarantee of funding if they say, I don't have any concerns, but what they can do is help you think about what pitfalls to avoid and how to, think very contextually about how you might fit in one of our funding opportunities. And then lastly, about the meetings, be thoughtful about the purpose and the concept for whatever your conference support is for. So if it's a meeting that you have every year, and it's just going to be like every meeting that you've had every year, that's probably not going to be compelling unless somehow magically it aligns perfectly with the goals that we have in this program. It really needs to be about something novel, about something related to PCOR and sort of the involvement of patients and stakeholders in the research process. So that's the information about the engagement awards. There's the ea@pcori.org. That's a phone number. If you go to our website, you can also directly get in contact with anyone who manages this program. And again, can't tell you enough, that is our wide open door policy. So feel free to reach out to anyone on that team. Oh, I'm sorry. Sure. I'll leave it up for just a minute. Okay, good. Thanks for asking for that. Okay, so this is the program that actually can go to individuals, and this is the Pipeline to Proposal Awards. These are very different than the engagement awards, but they sort of are born out of the same concept. So this is, again, kind of getting your ducks in a row funding. But the Pipeline to Proposal Awards was born out of a group of patients. We were having a patient engagement conference back in 2012, and someone stood up, and she actually was talking about rare disease, and she said, what if I am a person with a rare disease, and I live in Kansas, and I am not connected to anyone else who has my disease? I don't know any researchers. I don't know any research institutions. I know that patients are required on these PCORI awards, and so an institution will have to go out and find patients in order to submit and be successful. What do I do as a patient, given that I'm completely disconnected and I can't call you and get funding for research? Why don't you flip the funding and provide me a pathway so that I can have a shot at least getting connected to the research enterprise, at least being engaged in this process and getting connected to it. So that's what we did. We just flipped the funding upside down. So it's a very unique program. It's sort of analogous to maybe a small business incubation program where you provide seed funding, you provide a lot of training and technical assistance, and sort of build something together. So this is a 3-tiered funding process. At Tier 1, it's up to $15,000. So here again, these are much smaller awards. But if you're literally one person with a rare disease who wants to connect to other people, $15,000 could go a long way depending on what you want to do with it. So with that $15,000, it's all about sort of concept development. What we ask when you enter at Tier 1, we don't want you to have your research question in mind. We don't want you to have a fully formed comparative effectiveness research question or your PCOR question, because we want it to just be about what's your health problem, what's the challenge that you're facing. Because then, as you start to pull your partners in and collaborate, you're going to build your research question together. If you came in with a fully formed question, unless everyone that you pull in has that exact same question, it's not really the spirit of collaboration and working together to figure out what the thing is that you want to solve. So what we ask at Tier 1 is that you come with your healthcare problem. What's the thing you need to fix or the thing you want to solve? As I said, it can be an individual, it can be a patient, it can be a caregiver, it could be a clinician, it could be a junior investigator or a researcher who has not received a great deal of funding in the past and is interested in this as a pathway. The application process itself is purposefully much more streamlined. It's not pages and pages of statistical information. It doesn't need to be, because these are not research awards. So then moving from Tier 1 to Tier 2, at Tier 2, you must have at least a patient partner and a researcher partner. And we really encourage other stakeholders as well, so maybe clinicians or some other category. But you've got to have at least those two people. You still don't have to have your fully formed research question. You just have to be farther along. We're starting to narrow it down. We think we know what we want to do. By the time you get to Tier 3, what we expect is that you've got your whole team ready. You've got all your partners lined up. And now you're going to do the work of writing a research proposal. To get from Tier 1 to Tier 2, and you can see there, that's not a competitive process. You don't have to recompete. It's all about meeting those deliverables, meeting the milestones in your contract, and then you get sort of waived in or accepted into Tier 2. To get from Tier 2 to Tier 3 is competitive, and so that's going to take a little more work to resubmit and make sure you made a great showing in Tier 2, and now you've got a good plan for Tier 3, and then those dollars will be competed. And then at the end, so that the big blue box at the far end, The goal is that you've gotten your team together, you've figured out what your research question is, you've written your research proposal, and then you can jump into the big pool of PCORI funding or other funders. So it may end up that your research question fits better in a different funder, and that's fine. What we really care about is building that research capacity, building the pathway to the research enterprise. And so that will also be, of course, competitive into the PCORI funding, and then potential other funders would be up to your discretion as an awardee. The way this is built, it has two different sort of constructs. So what you see right there is what we call the successive pipeline. So you go tier 1, tier 2, tier 3. We will be opening up, probably, I would say within the next 6 months, an opportunity where you actually start at tier 3. So you just drop right into tier 3, you skip tier 1 and tier 2. And this would be, as you would expect, it's for a group that maybe is already too far along. You're not just one person or a small group of people. You've already got a research team. You already have a pretty solid idea of what you want to do. You just need time and resource and space to kind of pull all the pieces together. So you could drop into tier 3, that's up to $50,000, get your proposal all together and ready, and then you submit to funding after that period of time. In order to do this well, so even though we're not a governmental agency, the Government Accountability Office gives us an audit every year, and we are, we were created by Congress, we're overseen by a lot of different people. So we have to be really responsible stewards of our money. We could not just give out $15,000 checks to individual people and say, best of luck, we hope this works. We really needed to be really kind of tangible and helping. And we didn't have the resources to do that. We're located in Washington, D.C. We wanted these to be out in the entire country. So what we did was sort of the Robert Wood Johnson Foundation hub and spoke model. We divided the country into 4 regions, and then a 5th region, which is the national region, and I'll explain what that means in a minute. And each region has a program office, and the program office is actually managing the award. So they're providing technical assistance and training and really on-the-ground support. Many of them are also serving as fiduciary agents or fiscal intermediaries, because an individual person can't necessarily receive a $15,000 check. It might need to go through an intermediary. So we've got 4 program offices in all of these sites, and then we have a national program office that oversees an award that would be national. And this will sound really flip, and I don't mean it that way, but the difference between regional and national is if you have a regional award, it's because it's within that region and it doesn't extend beyond those borders. And if you have a national award, it extends beyond the discrete region, one discrete region. What we have seen is a lot of those national awards are either rare disease awards or communities that are all online, because you needed a critical mass of people, so you needed to spread outside of one discrete region. So far we've got 77 Tier 1 awards that are currently in the field. So this was an announcement that's been open, gosh, I can't remember how many months they've been out, but that's the Tier 1 set right now. We have 27 awards that started out as Tier 1, successfully completed Tier 1, and are now in Tier 2. As I mentioned, we will be opening up an opportunity where you can just drop right into Tier 3. That should be within the next 3 months. And we will be opening up another successive pathway where you start at Tier 1, move to Tier 2, and then on to Tier 3. So that's what the pipeline awards look like. Oh, and there's I got ahead of myself, but there's the upcoming opportunities. And then lastly, this is not a funding program, but it's something I want to just speak about briefly, because when we open it up to the public, which should be, I would anticipate this fall, hopefully, it's just a really good way to be connected to PCORI and connected to other people who are interested in patient-centered outcomes research, either as patients, as researchers, as clinicians, any number of types of individuals are involved in the Ambassadors Program. This is just an opportunity to share information, either PCORI sharing with the ambassadors sharing with their respective communities, or within the ambassadors community, people talking to one another. So right now we have monthly webinars where we feature a different research topic, or feature the work of an individual ambassador or an organizational ambassador who just talks about, this is the kind of stuff I do as a research partner you might be interested in knowing. So far it's been sort of a pilot project. So we haven't opened it up to the public. It's anyone who's attended a PCORI workshop or a roundtable or anyone who's on one of our funded awards. But when we open it up to the public, I just want you all to be aware of it so that you could sign up and become an ambassador. One of the goals, and I still don't know how we would make this work, but we talk about it all the time, is to turn the ambassadors program into a matchmaking program. So right now we actually do have some ad hoc matchmaking. If an external group comes to us and says, hey, PCORI, you have a lot of people that are interested in patients engaged in research. We have a technical expert panel that we're putting together on some research topic, and we would love to get some patients involved. So what we will do is put a call out to our ambassadors and say, is anyone interested? And then we do some like piece by piece matchmaking. So this person said yes, here's their email, et cetera, et cetera. What we would love to do is figure out a way that, respects confidentiality and privacy, but also facilitates matchmaking, because what we hear time and time again from researchers and patients and other stakeholders is, I would love to do work with a lot of patients in my community, but I don't know where to find them. And so we would love to be able to turn this into a mechanism, some sort of platform for people to find one another. And I think that's the end of my remarks. Can I take any, I don't know how we're doing on time, but I'm happy to take questions. Okay, great, okay. Any questions? Oh, oh, sorry.
Hi. Am I understanding it correctly that when in the process of let's say you're invited to file a full grant, and after your LOI has been accepted, that we could call PCORI and get help with the writing of our grant or advice on what we should be including?
So we have a couple different mechanisms. You definitely can call any of our program officers for either the science funding or the engagement award or pipeline funding, and someone is happy to talk with you and kind of troubleshoot about, does this seem like a fit? Am I in the right program? Are there things I should avoid? They do sort of keep they're not going to write it for you. So there's sort of a bit of a balance between being helpful and answering your questions and not being too directive. But it's very much an open policy where they're happy to take your questions. Even before the LOI phase, if you had a question for the science funding in particular about which of those 5, if you remember the 5 programs, if you called and said, I'm not sure which of the 5 programs I'm a fit for, they would be happy to talk you through which one made the most sense and where you should submit. But it is, yes, we're responsive, but it's sort of also a line between being directive and providing, writing it for you, I think is the best way to say it. So, yeah.
Well, do you have anything that, the frustration we experienced was the level of detail that apparently PCORI wants on what the patient involvement is. Right. And there's a lot of what we as a patient group would write our proposal, but we didn't separate it amongst the different members of the group, and we were criticized for that because the criticism was, well, there was only one patient who seems to be involved. Well, I took all the input of the other patients, and so how would you expect that to come across in a grant application? That's
a great question. So I didn't include it in this slide deck, but we have a slide that we call Show Your Work, and it's exactly what you're talking about. It just, I understand it feels very different from applying for other funding because we care about details that other funders just have never probably asked you to articulate before. So you could say exactly what you just said to me. So I, as a patient partner, synthesized and compiled the information and the input of 35 other patients to incorporate in this. I would say literally just walk through how did you go about this, who was involved. Another opportunity is to provide letters of support from patients that were involved. If they just want to do, a 1-paragraph, I am excited about this project, I helped with XYZ, and you could submit those along with the application. So I think it's just be as, it's almost, this is this is just occurring to me, but I'm thinking almost like bragging, like, look at the great work you did. You had all these patients lined up, you talked with them, you got all this input, so share that and I know it's limited space, but I would share it to the greatest extent you can to go into detail about all of those voices that were reflected in what you did.
And then assuming that the criticism comes back that, well, geez, we don't know if these other patients participated, would PCORI ever ask what was the involvement instead of just denying the grant? Or you
That's a
have to
good
put it in?
question, yeah. I mean, our merit review team would say the trick to merit review is always to really state your case so that when a patient reviewer is reading it, the patient sees it and says, this seems like it's pretty valid. We would not be in the business of sort of verifying or validating, certainly at the review stage, whether something, that's way out of our purview to kind of go in and reach out to those people. What happens after award, if you're a successful awardee, that's exactly what our engagement officers are slated to do, is be connecting with patients and other stakeholders and learning about engagement and helping troubleshoot and set up learning networks and talk through what engagement looks like and how to make it better and what PCORI can do to make it better. But before award, I've never gotten that question before. No, we would not go sort of prying, I guess we wouldn't go verify or validate. Yeah.
Right.
I'm not sure who was first. There's someone in the back.
Any more questions?
There's one back there.
Okay. I'm coming.
I saw one over there too.
Like, I'm moving fast.
I can fill this room with my voice. Hi, my name is Kristen Smedley, and I actually have two questions. And if the one is just too specific, then we can talk later. But you said if you're already doing something, this thing would, to apply now would have to be novel. One thing that we've done at our organization is research symposiums and research meetings. But the element that's missing is bringing the families in. And they can't afford it, and we can't afford it at this point because we're so new. Mm-hmm. Would this be something that, we don't want to bring the families in for the research component. We want to bring the families together to connect them with resources for living with blindness. I have a twofold mission, I'm trying to cure blindness, but at the same time, they have to raise these children well until that day comes. So I'm wondering if that would be part of the, quote, novel that you're talking about, to connect families at the same meeting, that I'm not going someplace twice.
Yeah. So I think there could be a way to do that. I'd want to, and maybe we can talk offline. I think it couldn't be purely about sort of disease management and quality of life and figuring out how to live effectively with this condition, because research always has to be a component. So is there a way to also bring families into the fold of the research discussion? Maybe they get exposed to part of the research symposium, learn about it, learn about basic research concepts, learn about the research that's going on in that disease, because there's got to be a nexus to research somehow.
Oh, I'm so sorry, then I misunderstood. I thought it couldn't have anything to do with research.
It can't be a research award, but the conference or the activity has to be about research.
Perfect.
So training in research or knowledge about research.
Perfect.
Yeah.
Okay, so that's perfect. And then my second one is along those lines of raising blind kids well, another thought that we would like to do is put together almost like a toolkit. Although, it looks different for every family, but where you go what you're going to need to do when you get that diagnosis, and have it in the hands of every ophthalmology specialist as well as the families. Is this something, and we just don't have the manpower and the resources at this point,
Right.
Is that something that would qualify?
So I would say you have two potential avenues for that one. It's got the same challenge to it, which is that you've got to have a research component. So for an engagement award, if you were going to maybe do a training about living with this disease or how to combat it instead of a toolkit per se, there's got to be a research component. So part of it or a main part of it would have to be about exposure to research as part of what you're accomplishing. The other option is our communication and dissemination research science portfolio, so one of the large science awards, and how you could sort of leverage these types of tools for better healthcare outcomes. The trick would be you'd need a comparator, because it's comparative effectiveness research. So maybe it's usual care versus care with a toolkit or a set of guidance tools to help navigate. But so I would actually reach out to someone who's a program officer in our CDR team. And again, this is all on our website. It's a very dense website, but it is there if you just go through a few pages. Because I think a program officer on CDR could maybe talk to you about whether that could be a fit. But those are large awards. I mean, they're significant, usually upwards of $1 million, or somewhere between 500,000 and $1 million. So those are large awards.
Okay, thanks so much.
Sure.
I think we had another question over here. Did you?
I was actually just going to make a comment that integrating researchers with patients and families is actually one of the best things you can do at a meeting. It's great for the patients and it's great for the researchers. Patients and parents want to know what's happening in research. And when I was a PhD student, actually seeing the patients motivated me to do my research. So I would actually argue that it's an ideal situation.
Thanks for that comment. There's a couple models now. I think it's the Neurofibromatosis Foundation. They do, you do poster presentations at scientific meetings. Now they have families posters up at the poster presentations. It's phenomenal. Yeah. Yeah. Any other questions? I think is that it?
Oh, absolutely. Another question.
Because we're also a new organization, new to the grant writing and applying for grant, the process. We do have some really great researchers and clinicians that are involved with our patient group. My question is when you go to apply for the grant, are you also looking, since we're a foundation, does the foundation only apply, or do you need a medical institution to kind of back that up? For instance, we have Texas Children's, we have one of our researchers at Texas Children's who is able to help us. Is that something that you require, or is that better?
Right. So I have 3 different answers for you for the 3 different, and hopefully they all they don't contradict one another. For the 3 different types of funding. So for the pipeline awards, where it was the tier 1, tier 2, tier 3. An organization could certainly apply at that tier 1 level, or potentially even at the tier 3 level. So you would not have to have an academic or a institution applying. For the engagement awards, so again, not research awards, but those 3 buckets of engagement awards, the knowledge, training, development, dissemination, an organization can absolutely apply. You don't have to have an academic partner. For the science awards, it's a little bit complicated. Technically, a foundation could be the primary applicant, but you would have to have an academic institution or someone, like you mentioned, that's there because you have to prove that the science, the methodology is going to be rigorous and it's a strong, comparative effectiveness clinical study. But we do have an example where a patient advocacy organization was the prime on the contract, and then they have a sub with a large research entity. Either way, even if the academic institution was the primary applicant, what you would just want to do is be very, like we were just talking about, be very out in front throughout the proposal, very strong engagement voice, make sure that patient voice is really coming through. So I think you've got several options depending on what you'd be looking for. All right. I think that's it. All right, thank you so much.